All right, good afternoon once again. We are going to get started now. It is 2:35 by my clock, and we have lots of wonderful information to share with you and want to allow time for you all to ask your great questions. Thank you for already chatting in. So welcome to our Early Childhood System of Care learning community. Today we are focusing on home visiting and systems of care. My name is Lauren Rabinowitz, and I am here with the TA Network. I am joined by colleagues from around the country. I will do some more in-depth introductions later, but I am here with Kate Wasserman from Maryland and Janet Horace and PJ West from Iowa, where I just heard it feels like 11 degrees and they have a foot of snow in parts of the state. So I'm feeling less annoyed by how cold it is here in Washington, D.C. So as we are getting started, feel free to continue putting your name into the chat and anything that you would like us to know. We are interested in what brought you to this learning community here today and what it is that you would like to know about. So as I said, we are talking about home visiting and systems of care. These are two complementary approaches for early childhood mental health, and they are big topics. We won't be able to get into all the nuance of both today, but we are hoping to give you a nice flavor. You're going to hear about a wide range of home visiting and system of care efforts, and we really hope that you come away from this time today with a better understanding of how these approaches complement each other. If there is very specific information that you are after that we don't have time to address or doesn't come up, we will be providing our contact information. We'd love for you to get in touch, and we will certainly provide you with any information that we possibly can. All right. So, for those of you that have not joined our Early Childhood System of Care learning community before, I'll just talk very briefly about it. This is a time that is designed to support all of those that have an interest in early childhood systems of care. So once upon a time, this was really geared towards SAMHSA grantees or those that had an early childhood system of care grant, but we are really broadening it. Anyone that is interested in talking about this topic, we welcome you and are excited to have a great group today. We are addressing all sorts of different topic areas, always with that theme of early childhood mental health within systems of care, but as you can imagine, that's broad. So we have lots of different topics. We have our chat box that is available. Lots of you are already using that. Please feel free to put any comments or questions as we go through. We do have the lines muted now. We will be opening up the lines towards the end of our time after our speakers have had a chance to talk. If you have any questions, though, please don't hesitate to put that in. We'll be watching out and make sure that all questions get answered as we go. There is also an evaluation. We will be providing the link for that at the end. And please do complete that survey. It's really what helps us make this a successful learning community. And as I said, here are the folks that I am lucky enough to be presenting with today, Kate, Janet, and PJ. And I will give them more in-depth introductions as we get to their pieces. Okay, so for our agenda, we're going to start by talking in very, very broad terms about evidence-based home visiting and systems of care, just to ensure that we are all on the same page. And I'll then be turning it over to Kate in Maryland, and she is going to share some background on kind of the overall home visiting landscape in Maryland, and then do a deeper dive into some of Baltimore's assessment and referral work. And then we'll turn it over to Janet and PJ in Iowa. They're going to give some broad strokes about their MCV program and then focus in on their newly forming mental health consultation program and how this is enhancing their home visiting work. And we will then have lots of time for discussion and peer learning. This will be your chance to share successes, challenges, ask questions, about what was presented or about anything else. And then we're going to briefly at the end mention our learning community in 2019. It's going to look just a little bit different, and we want to share some of that with you. All right, so with that, let's jump right in. So in thinking about evidence-based visiting and early childhood systems of care, I'm actually going to start with how they are different. So evidence-based home visiting refers to a service that is delivered. There are many models for home visiting. There are close to 50 that have some level of evidence and about 20 that meet the Health and Human Service criteria for being evidence-based. So this is referring, if we talk about evidence-based home visiting, we're really talking about the delivery of a particular model. System of care is a little bit broader. System of care is many different services and supports. But what's kind of funny about that one distinction that I'm making is it's actually also how they're the same. So how they're the same is sort of how they're different. And what I mean by that is you really can't be implementing any of the models of home visiting without also talking about housing, primary care, education, etc. If you are sitting with a family in their home, it is, talking about issues that are coming up with a pregnancy or with a new baby. All these other pieces will come to light. So that one kind of distinction is not always so distinct. So what I want to spend a little more time talking about is really how these approaches are the same. They're both about reaching families in a natural environment. They have very important similar core values. So you see some of the core values on the slide about systems of care, and that they are, so these are specifically system of care values, that it's delivered in a natural setting, family-driven, there's this connection with other systems, but every single one of those could also be used when discussing any of the evidence-based home visiting models. And then another important similarity is there's a strong focus on early childhood. This might be a little bit more explicit in the home visiting world, but is certainly a thread in the system of care world as well. If we were to make a Venn diagram with these two different approaches, we would see a lot more in the middle about the similarities than the difference. The difference really winds up being more on the implementation side. Like for example, a home visiting program could be a service that an early childhood system of care is offering. And one other comment I want to make is that whether we are talking about systems of care, whether we're talking about home visiting or really any other early childhood intervention or approach, we always want to be thinking about the family voice. It is so crucial to make sure that all voices are heard and represented. Okay, so now I want to talk just a little bit more specifically about the federal home visiting program. So this is the Maternal, Infant, and Early Childhood Home Visiting Program, MICV. And I have listed up here the 6 benchmark areas. And I put this up here for those that might not be quite as familiar with the MICV program, that maybe know a little bit more about the system of care programs, or the system of care approach, because I think it's just really interesting to see the similarities. So these benchmarks really have a lot of close correlation with the system of care aims and guiding principles. I think really the difference is these benchmarks are a little bit more specific, and they're more outcome focused than implementation focused, as we see in some of the system of care guiding principles. And this slide here, I have some information about indicators and evaluation, once again, to just help ground us in some of the similarities and differences in the approaches. So with home visiting, the evaluation looks at 2 different sets of indicators. So it looks at performance indicators and system indicators. For performance indicators, we are really looking at those that are being served. So what are the demographics of those enrolled? How frequently are they receiving services? And just some other kind of clinical indicators, kind of general functioning. And then home visiting is also really interested in system indicators. So are participants getting referred to other needed services? Are they having insurance coverage? What's the education level? Different issues like that. And with system of care, again, just a little bit different, but you can really see some of the similarities here, that evaluation looks at services and supports and then child and family outcomes. So with services and supports, we're looking at these more specific clinical services, sort of what are families receiving, are they getting linkages and referrals to other services? And then looking at child and family outcomes. So it's, again, very similar, but you can see some interesting nuances in the difference there. So this was a very quick little overview, but just really wanted to set a frame as we hear from our presenters. And I think if there was, one thing I could hope that everyone comes away with today, when it comes to home visiting and systems of care, I don't think of it as an either or, but it's really an and there's lots and lots of different ways that these approaches can work together. All right, so we are going to turn it over to Kate Wasserman. I'm going to give a brief introduction for her. So Kate is the co-director of the Parent, Infant, and Early Childhood Program with the Institute for Innovation and Implementation at the University of Maryland School of Social Work. So there she oversees program and policy work for the early childhood projects across the state of Maryland. And as some of you heard, she is currently literally driving across the state of Maryland as we speak. And so her work includes the state pyramid model implementation and 2 system of care grants. She is a licensed mental health clinician with a dedicated focus in infant and early childhood mental health and maternal mental health with expertise in public health policy, program development, and direct service. She is a graduate of the 0 to 3. She is a graduate 0 to 3 fellow, as well as a national trainer of the Fussy Baby Network, and previously served as the lead trainer for Maryland's Race to the Top and Project Launch Workforce Development Grants. She holds an MSW from the University of Maryland School of Social Work, where she focused on maternal and child mental health, and a bachelor's in political science from George Washington University. Take it away, Kate, and let us know when you want us to advance for you.
Perfect. Yes, thank you very much for the opportunity to join while literally in motion throughout the state of Maryland, and I apologize for any car noise that you guys hear throughout the sides. So I will take this opportunity to share a little bit about what the landscape and sort of efforts are from state leadership in Maryland to really organize home visiting from a policy perspective, and then as Lauren said, taking a closer look at what that has meant for a target population in Baltimore City across the past decade throughout that effort. So as you'll see on the slide here, I tried to outline a couple of different initiatives throughout that the state leadership at Maternal and Child Health have used. The first back in 2010, the state received a Pew Charitable Trust home visiting campaign fund that allowed the leadership at that time to really align state funding policy with much of the McBee federal guidelines around home visiting and funding and priorities there. And what that did was really help us organize what was, before that time, a very, very broad service array of, or rather a very large bucket of what home visiting could be, and many programs really running the gamut between dosage and focus and disciplines and models. So they used that funding to really align with the McBee federal guidelines. And then, as anyone knows, the best way to sort of solidify policy is to have regulations passed. So the legislature in our state in 2012 passed the Home Visiting Accountability Act, which really solidified regulations around funding priorities for home visiting. So that legislation mandates that at least 75% of programs funded with state funding need to be evidence-based, and up to 25% can be in that promising practices sort of bucket that Lauren was referencing before, as I think a way to acknowledge that the field is still growing in this way, and that there were programs and interventions that were worth paying attention to or worth attributing to in our state that weren't yet at that evidence-based practice threshold. And that the reporting measures were really focusing on these 5 elements. So child development, or child health rather, so overall health outcomes and compliance with primary care guidelines, tracking child development and getting them into early intervention early when indicated, really focusing on maternal mental health outcomes, what are some family considerations for child well-being, and then and documenting any levels of special need for kids that were enrolled in services. So taking a look at, after that, those regulations were applied across the state for several years. In FY17, 58 programs reported employing, the number here, as you can, anyone can appreciate the specific data collected. Here, it says that it's 207.8 full-time equivalent home visitors, so I guess the sum of many part-time folks, but across the state in those programs. And then you can see the numbers here. It was a little bit over 4,500 women served, reporting through 58 reporting home visiting sites across the state, and really targeting women. Half of them were between 20 and 29 years old, and over 70% of them were representative of minority races or ethnicities, and you guys can advance the slide there. And then I just wanted to spend a little bit of time over the course of the next little bit talking about what that's meant for the programs. And the leadership at the State Department of Health has really been able to solidify focus on these 5 different programs here. So Nurse Family Partnership, Healthy Families America, Families and Parents as Teachers, the HIPPY model, and Early Head Start. And so it's really been able to kind of prioritize where funding and where focuses go from the state perspective. And then there have been a number of formula grants that have also supplemented some of the sort of competitive federal funding to meet the need as it exists in different areas of our state. And as you can see here, there's 6 jurisdictions that allow for, or that follow this formula funding based on the population need and the need for more infusion of home visiting throughout those jurisdictions based on economic and socioeconomic needs in those places. And as you can see here, the places that you would expect. So it's Baltimore City and Prince George's County, which is a suburb of D.C. And then these other counties are either on the eastern shore or on the far west of Maryland, sort of the more rural and isolated areas. So an effort to really build up workforce capacity and program capacity to address the need in those different jurisdictions. And then another thing that the state has done and committed to with the McVie federal funding is contract with the University of Maryland, Baltimore County to develop a 7-day comprehensive certificate course for home visitors. And we know through any of the McVie efforts that any of these models, Nurse Family Partnership and Healthy Families America, they have very robust training and sort of onboarding programs for any home visiting staff or supervisor. But what the state felt was missing from that existing sort of place or space was really some guidance around, when home visitors were addressing things like domestic violence or substance abuse or maternal mental health concerns in the home. And so you can see the faculty that they contracted with at the University of Maryland really specialized in motivational interviewing and addressing substance use in parents. And developed these sort of 6 categories that make up this 7-day comprehensive certificate course that they've now rolled out for several years in our state. You can go to the next slide.
Hey, Kate, while we're transitioning to the next slide, we had one question that came in about that specific training. There was a question, is that home visiting based on a specific model, the training?
No, so the intention was to hold true to the McVie sort of endorsed EDT models, but to have to have something that cuts across any of the McVie models, if that makes sense, if that answers the question. So what are some of the skills that anyone working within Healthy Families or Early Head Start or Nurse Family Partnership would need when they're thinking about assessing maternal mental health or discussing parental substance use or things like that with caregivers. So I think it was really the state's effort to supplement those existing training programs, given the acknowledging the severity that a lot of the workforce walks into when they are in the home and in the indicated most at-risk population. Great. And yeah, I don't have access to the screen, so if there are any other questions, yeah, please feel free to jump in with those, Lauren. Thank you.
No problem.
I wanted to take the opportunity as well to look a little bit more closely at what Baltimore City has done, because they've really been able to anchor a public health effort around home visiting, but within a larger system. So as Lauren was going over many of the intro slides about how to think about home visiting with respect to a larger system of care, Baltimore City is a really sort of intentional illustration of that, and has had some pretty great outcomes. So if you look back to 2008, so over a decade ago, the infant mortality rate in the city itself was the fourth highest rate in the United States. And in addition to the poor infrastructure and sort of large isolated poverty neighborhoods that many urban cities address in today's reality, there were some specific things that the public health workforce of the city was sort of uncovering as they were looking at what was contributing to this high infant mortality rate. And the biggest thing was really, globally unsafe sleep practices and really high rates of preterm and underweight births as a key indicator of that. So the health department conducted a needs assessment to look at what the home visiting workforce was doing at that time. And at that time, there were 10 different home visiting programs across the city, and they were using nine different curriculum, and there was inconsistent eligibility and outcomes, and there was a true lack of coordination, both among the home visiting agencies themselves, but also between referral sources. And so there was a real lack of understanding of what home visiting could do. So in 2010, the city health department launched what they and we all refer to still as Be More for Healthy Babies, so Be More as an acronym for Baltimore itself, and looking at really coordinating referrals and targeting families that would be seen as lifted up by the two models that they chose to focus on. So rather than 10, they chose to focus on Healthy Families America and Nurse Family Partnership, really because of the indicators of infant mortality that I referenced earlier. But not only just investing in the workforce and sort of some funds that went to those programs, there was a really big campaign, a public education campaign around safe sleep and around home visiting as a resource to support that, as well as smoking cessation, because that was seen as both an indicator for health outcomes during, for risk for prenatal delivery, and then also just poor sleep, for risk of sleep for babies. But then also they employed prenatal risk assessment. So at every initiation of OB care for pregnant women in the city, primary care doctors and OB doctors were instructed to fill out this needs assessment that was then sent to a central location that tracked and then automatically triaged eligible families into either Nurse Family Partnership or Healthy Families America. And they decided to track women that had more of a medical indication of need, so a history of obesity or history of diabetes or history of other fetal loss, into Nurse Family Partnership, just based on the expertise of that program. And then many others were triaged into Healthy Families America. And then if we could just go over to the last slide, this looks at some of the outcomes. So after that, really sort of coordinated but longitudinal effort. I mean, there was many years of it was hard to drive past the street without seeing one of the Safe Sleep campaigns. I mean, it was a very concerted effort by the City Health Department's part and a commitment to sustaining that public campaign. They were able to illustrate some really great outcomes. So what I have on this slide is two different things. I have some of the outcomes that they were able to illustrate between 2009 and 2016. But then also the chart on the left looks at what does some of the sustained and braided funding look like. So at the end of this, and again, that's always a question, right? Is we get some, federal or state or nonprofit money to sort of initiate an innovative application of something, but then how do we sustain that once that initial opportunity goes away? And as you can see here, they've really been able to, at the end of FY16, really illustrate a braided funding model. So there's 10% that is offered by the city, 6% by local foundations, Department of Health and Mental Hygiene, that's the DHMH portion here. Some of it is public health, so some of the block grant dollars is almost 50% of it, but then also using some Medicaid funding to cover 15%, and then covering 13%. And this is, of course, just funding in the city, but I think a good illustration of really breathing in opportunities and spreading the cost of home visiting across a couple of different buckets. But this effort to really target the most at-risk families with a true wraparound approach has, as you can see here, had a 35% decrease in infant mortality by 2016, a 64% decrease in the black-white disparity in infant mortality, and Baltimore City itself is very minority heavy, so that's a really significant outcome for the city itself to be able to illustrate, given the disparity in numbers themselves. 49% decrease in teen birth rate, 75% decrease in the black-white disparity of the teen birth rate, and then a 71% decrease in sleep-related infant death. So, I think that they were showing that the organization and really sort of wraparound effort around, targeting families that were most at risk for these services really helped enter a lot more into the home visiting programs, which we know have proven outcomes across the country. Another thing that they did with the McBee funding, which I think was a little bit innovative, although had a little bit less of an outcome, is really try to educate a lot of the primary care coalition, so the primary care pediatric doctors about it, that there was sort of this question that I think our state is still struggling with, and so I welcome the discussion or feedback from others or ideas of others about this. But how do you support communication between pediatric primary care and home visiting programs? That they found a lot of times parents just don't know to inform one about the other, and often they can reinforce a lot of the same efforts or work to re-engage families that may have sort of stepped away from either service at either time. So that's the landscape in Maryland currently.
Thank you, Kate, so much. That is excellent, excellent material. And there is one question that came in. I believe this is for you, Kate. Jill was curious, was the impact of the Healthy Start program evaluated as well?
So Healthy Start was not evaluated in Baltimore City, no.
Okay, thank you so much. I'm sorry, and there's one other question. I'm just reading as it comes in from Mike. He said, since the inclusive criteria for both HFA and NFP is fairly narrow, are there hopes to expand these programs to include multi-children families who continue to require significant support, especially in light of substance use and NAS? Great question.
That's a fantastic question. And one of the biggest limitations that we found was that the criteria for inclusion once the child is discharged from the hospital is much higher, and so the sort of efforts to engage primary care were difficult because they weren't able to, if families weren't referred either during the prenatal period or prior to discharge, even if it was their 2-day post-discharge visit from the hospital, the criteria was much higher. So I think it's certainly a pitch to the city, and they acknowledge sort of the need for that. And part of the effort is around, can we find literature that illustrates the same or similar outcomes when a child and family are engaged later? Because much of the outcomes for both of those models specifically is more impressive for families that are engaged during the prenatal period.
Thank you so much for that. I see there might be another question or two coming in, but we will, here's one more. What did it take to get the home visiting legislation in place? Oh, and she thinks this would be a great follow-up webinar, and I agree. Did you want to comment on that briefly, Kate?
Yeah, I mean, I think it's all about people being in the right place at the right time. So I think it was, the Department of Mental Health and the Department of, the Department of Mental Health and specific behavioral health leadership at the time. It was, I think, a clear sell, and so they were able to make a concerted ask at the same time that a lot of the sort of federal McBee stuff was coming out. So it was, I think, really a plea from the state leadership to help align Maryland with where others in the country had already gone. And then, there was a lot of federal funding at that time coming down the pike for home visiting. But I think it was sort of those three. It was a sort of perfect opportunity with those three factors being in place at the same time. But like anything else, it's who was at the table to decide it. It's all people, right?
Absolutely. Okay, thank you so much, Kate. Keep the questions coming, everyone. This is fantastic. So we're going to transition now, and we're going to hear from our colleagues in Iowa. I'm going to introduce both at once. So Janet serves as the State Home Visitation Program Director for the Iowa Department of Public Health. She has been employed by the state of Iowa since 1999, and Janet has a total of 29 years of experience in the home visiting field, starting her career as a home visitor in 1989. Janet and her husband have a total of 8 children and 8 grandsons, which keeps her well-grounded in the joys and frustrations of parenting. And PJ is the program manager of the Iowa Department of Public Health's Maternal, Infant, Early Childhood Home Visiting Program. Ms. West has worked within the family support arena for 20 years, having been the coordinator of a local family support program that serves FIP families through home visitation. And in PJ's current role at the department, she provides program management at both the state level and to local MCV contractors, as well as serving as a trainer for the Lemonade for Life and the Futures Without Violence Healthy Moms, Happy Babies training. PJ truly believes in helping professionals understand their own stuff before they can successfully help others with theirs. Thank you so much, Janet, and PJ, the floor is yours.
Hi, everybody. This is Janet Horace, and I'm so excited to be with you today, and I know PJ is as well. And I was reading the questions and even the comments that were coming in when we first started about the things that you wanted to learn in this community of practice, and thought, boy, I hope we get invited back, because that's a lot of topics, but I do think that we have a lot of expertise in several of those topic areas. We also had legislation pass in 2012 with the help of the Pew Home Visiting Campaign, and it was a phenomenal innovative practice to be able to be part of that. And I would say that the key to having that happen was timing. It was like the perfect storm, as Kate mentioned. But I also think the other piece that I think was key was that Pew had funding to hire a lobbyist specifically to work on this issue. And the lobbyist, or the lobbying firm that they engaged, it was a bipartisan lobbying firm. So they had one Republican, one Democrat that worked on this for us with great connections. And that, I think, made the difference, because I think, I could say that these things were all important, and it would not rise to the level and the top that these guys were able to do. And they were able to make connections with businesses. And when you get the CEO of some of the big businesses contacting legislators saying, you need to do this, it happens much more quickly. So that's just a little tie-in from what Kate was talking about at the end with the question that she received. The slide that you're looking at right now is just from this past fall. It's harvesting soybeans, and that happens to be my brother. So we're not all farms in Iowa, but farming is very important to us, and I wanted to share that picture. Oops. So we began, PJ and I both work with home visiting in Iowa. We primarily work with MCV, but we also work with state-funded home visiting in Iowa and coordinate those services. We do have home visiting in all 99 counties in Iowa. We serve around 20,000 families a year with our different funding streams. We've been serving families through home visitation since 1989 in Iowa. We are fortunate that our state recognized that early on. But this is the first year that we've been able to offer mental health consultation. I mean, we are just getting this off the ground. We've wanted to do it for a while, but this is the first time we've had money designated to be able to do that. And what we did was we specifically are doing this only in our MCV program at this time. And the nice thing about our MCV funding and our MCV contractors is it's a small enough group that we can try some innovative practices and see how it works before then we could take it statewide. So we kind of use our MCV sites as a little bit of a laboratory, and the mental health consultation would be an example of that. So each contractor, and then when I say each contractor, I mean our contractors for McV-funded home visiting. And we also support 4 different models, so all the same as Maryland, except we do not support HIPPY in the state of Iowa. So it's Early Head Start, home-based Early Head Start, Nurse Family Partnership, Healthy Families America, and Parents as Teachers are the 4 models that we support financially in the state of Iowa with McV funding. So they each were given money specifically for retaining a mental health consultant. And the mental health consultants, I'll get into a little bit later, or PJ will, about what they can do and what they can't do. But one of the things that I was told early on was make sure that you don't make it such a measly amount that no one would be interested in this, or even if they are interested in it, they couldn't afford to do the work. So what we did was based it on a $200 per hour, and that may not be generous in other parts of the country, but in Iowa that's a pretty generous amount, and saying realistically, how much time do home visitors have to spend in consultation? So we thought 10 hours a month per contractor to get us started, and not saying that the whole 10 hours would be in direct consultation with the mental health consultator, consultation being given to home visitors, but that also includes prep time, follow-up. So a portion of that would be in direct service to the home visitors. And so our focus really was to be proactive and focus on prevention. So the activities we cannot support, we cannot provide direct services to the home visiting participants, and that is a HRSA standard. We cannot provide medical services or mental health services, dental or legal services, just their rules. We also are not going to provide individual consultation to non-McV staff. We've said if there are other home visitors that are not McV funded that want to sit in on consultation, that's fine, but we don't want to take away from providing it to the McV staff. And we also don't want to use this as a replacement for mental health services that may be needed by individual home visitors. And so if they need therapy, we want them to get therapy. This is not a replacement for that. This really is to help them be more effective in their work with the families that they're assigned to serve. So the types of activities that this can support is home visitor training. We see that as probably going to be one of the high ticket items that people will want. Just team consultation is working together as a team, individual consultation to individual home visitors, and also training for the mental health consultant. And I think PJ is going to talk about this in a little bit, but we decided to go, instead of having the state do contracts with some mental health providers, we're going to let our local contractors choose their own mental health provider. In that way, we're hoping to build the capacity at the local level. And you're probably thinking right now, geez, are you really going to be able to find mental health consultants in these rural communities in Iowa? Probably not at the level that we need them to be at, but we're going to invest funding, get them trained, get them the training that they need to bring them up and increase the capacity of those mental health providers that are chosen at the local level. So we expect them to be able to provide consultation regarding all ages. So we've worked really hard, and I know many states have, on infant mental health and including infant mental health consultation. But we want to take not just infant and early childhood, but the parents as well. And it could be even an older sibling that's involved in the family, that's a member of the family that's, when one member of that family unit is suffering, it impacts all of them. So we're expecting them to be able to provide consultation on all ages, the entire lifespan. And then again, that includes the preparation and follow-up of the mental health consultation. Oops. So these are our McV home visiting sites, and this is just a map of the state of Iowa. And it may be a little hard for you to read on the screen, but just to give you some general reference points, on the east coast of Iowa, we are bordered with the Mississippi River. On the west coast of Iowa, we are bordered by the Missouri River. So we refer to our east and west coast, but it's not the same thing as what you're thinking in California or in Maryland. So no oceans, just a big river. And you can see that most of our McV sites, because we have 13 targeted counties or communities in Iowa, they are outside of central Iowa. And central Iowa is where our capital is. So for us to go to any of our McV sites, it's a couple-hour drive. They're not close by. They're a few probably 60, 70 miles at the least away from the capital city. So we're a lot of border communities, meaning bordering with other states is where our sites are located. So I want to do, let's see, I think now I'm going to turn it over to PJ, and then we'll take some questions at the end if there are any questions.
Okay. Thank you, Janet. As Janet showed you that map and talked about our MCV contractors, we have 6 MCV contractors offering services in 13 counties. And as we talk about multiple mental health consultants versus one, as the slide says, we really wanted to give some of that, all of that hiring power to our local contractors. And at last look, because I'm serving as some coordination for this project, out of our 6 contractors in those 13 counties, 3 of our contractors have hired their mental health consultants, and we still have 3 of our contractors who have not. That doesn't mean they're just hiring 6 mental health consultants. I think we're upwards of 8 mental health consultants for 3 areas so far, and then 3 programs are yet to hire. So we really wanted to give them the power to hire what works best in their area, who they have available to them, and with that came, one of the most important pieces, which is that capacity building. We're giving the power to the local program to hire and to figure out who works best for them, but also to build capacity with the mental health consultants and the local programs, which it's very parallel to working with families. It's about relationship building and building capacity. Keep in mind, as Janet said, we are in the very beginning stages of this process. Our contracts just went into place October 1st. So some programs have hired their mental health consultants and some have not, but they are working on it and we're staying up to date on that. When Janet showed you that map, we have both urban and rural MCV programs in the state. And as Janet said, we are spread out a long way. And I will tell you that, yes, it's very snowy in southern Iowa. I live in a very rural community. And if I wanted to seek mental health services, it would take me 45 minutes to an hour to get to the closest mental health services location. So we really thought it was important for our local programs to be able to find what works best for them in their area. We really needed to think about that. And so you can see by the second bullet on this slide that we have thought about the use of telehealth as an option for those rural areas. And as of right now, our MCV sites have not needed that, but it's something that we want to talk about and we want to consider. I know Janet talked about how we are just getting started and we're starting small with our MCV sites, but this may also be an option if this ever expands across the state, because there's, in some places in Iowa, there's not a lot to available right in those local communities. I've talked already, and Janet spoke of this too, is we're really honoring that local control and letting our local programs decide what works best for them. They know better what their program looks like, what families look like in their area. I always say, working with families, every visit is a new and exciting adventure. It's like that in every community. It's very different, even if we're just a county apart. So we want our local programs to have control. And we recognize those regional differences. Also, when we talk about federal funding and MCV funding coming into our state, this is additional funding going to local communities. And I know Janet talked about on the last slide that this is specifically for MCV programs, but if there's a training available that's happening and we can invite others into that, that's great. If we do need to do sort of a team approach for a family and another home visitation program could attend that, that would be great. So we really want to support local communities, but right now we're really focusing on MCV programs specifically. The next slide, and I know that the organizers of this webinar have this report brought up. If anybody wants it, it's going to be available to you. But we identified needs, and in July of 2015, the results of the Iowa Family Support Workforce Survey stated that adult and child mental health and substance abuse were the 3 areas that home visitors felt the least prepared to handle. We are super hopeful that this particular project will help support our family support professionals. We really want to help them with what they need, and I think this is something that we hear all the time. I would say in my time in family support programming, those are definitely 3 topic areas that folks always want more of. When we go out and we have meetings, this is the one thing we always hear about is mental health for children and adults and substance abuse. Also, we do MCV site visits, and we just came off of those fall site visits, and I know for each of my programs, this is one thing that they always say they need more of and are always seeking more training in is adult and child mental health. So we really hope that with this project, we are able to meet that need and help support local programs and staff better. And as Janet talked about earlier, we've wanted to do this project for quite some time, and it was actually wrote into our 2015 MCV grant, but this is the first year, fiscal year 19, is the first year funding was identified for implementation. So we were really excited to get that working. All right, so missing pieces, and I know when this PowerPoint was put together, that was several weeks ago, and we have learned a lot in those few weeks. These are some things that we are feverishly working on, and as I said, we have some local programs who have already hired their mental health consultants and are working ahead to do that. We still have some areas who haven't, but we are learning, and we are looking to other states. I recently had a meeting with the state of Illinois on their mental health project with mental health consultation, and it was amazing, and they have learned over time what works. And so some of the pieces we've already built in, they have said this will work great. But we have a lot of check-ins, too, about how that will work. But one of the things that I mentioned earlier and that we are talking about now is we didn't think and talk about coordination of mental health consultants, and so that's the role that I am serving in for MCV in the state of Iowa now, and it's been fun. And I know Janet even said, I'm glad to see you so excited about this, and I am. I think if we can empower our local programs, we're doing good work. So we want to think about a mental health consultant is more than just a mental health therapist. There is a difference. There's a difference in therapy and consulting. Consulting is demonstrating an ability to implement a consulting stance, avoiding the role of the expert. And we need to think about that, and we want our local programs to think about that. And also, when we're talking to our mental health consultants about the role that they're playing, we want to work collaboratively with families, parents and children, families as a whole, to understand behavior and to identify and implement strategies that meet the social and emotional needs. And as Janet said, mental health consultation in Iowa is mental health consultation to our family support professionals. And our professionals are the ones that are working with families. They know what's happening in that family's home, and we want to make sure that we're supporting those family support professionals to the best of our ability. Things that we also need to consider as we're moving through, this being an effective strategy, the point of entry, how the consultant is an ongoing part of the program and can be called in when there is a concern. We want to make sure that our local programs and our local mental health consultants understand that process and are really looking to see how that works for them. Frequency and duration. We need to have a consultant, and we need to look at, how many hours a month is this going to take? And we're looking at around 10 hours. And what I'm hearing from other states is, yes, we're absolutely spot on by that. But that doesn't mean that might not change, and we might find out that something else is going to work better. So keep in mind, we're still learning, and we will revisit that if we need to. We need to consider the activities to be included in mental health consultation. How will we know if mental health consultation is effective? We want to look at an evaluation process, things such as tracking, reporting, testimonials, not only from the mental health consultants, but from our family support professionals and local programs. We want to make sure that regular meetings are happening, as I talked about before, and that we have some demonstrated outcomes. That's super important. Quality assurance with site visits and to survey sites to gather feedback on what's working and what's not working, and then supporting the consultant. We may have consultants that don't know much about in-home family support programming. They may not know about our evidence-based models, and we want to make sure that they're getting what they need. So part of my coordination is going to be that piece and helping them understand their role and asking them what they need, but also helping them to understand what's happening in a home visit, because not everyone understands this work. So comprehensive training, ongoing support, monthly check-in calls, connecting with the consultants and making sure they connect with one another. I can facilitate all sorts of conversation, but really the power comes when they're connecting with one another and talking about what's working and what's not working, and to share, emerging resources. So we are very excited to get this project off the ground. And again, we are brand new into it, and we are learning at a very fast pace. But we are excited, and we can keep you updated and are excited to see where it goes. So thank you.
Well, thank you so much, both Janet and PJ, for sharing that. Your enthusiasm was really clear and so nice to hear. It's fantastic. So at this time, you can please, anyone, feel free to put questions into the chat. It looks like one person might be putting a question in, but Tiara, let's also go ahead right now and unmute the lines. Really want to encourage folks, if you have a question, have a thought, this is a chance to share. This is really your time. We have some great experts on the line, and there are 41 of your colleagues also on the line that I hope are interested in having some dialogue. So you can use the chat or go ahead and use your phone. I think the line should be unmuted. Okay, one question has come in from Minette. I hope I'm saying that right. So Minette is wondering more about professional development opportunities that can be shared. So Minette, you either can, between ECE staff and home visiting staff. So this is a really big, important question. I think Kate was talking a little bit about that. She was talking about the one training opportunity. So let me first ask if either Kate or PJ or Janet wanted to comment on that. I have a couple thoughts as well, but let me just repeat the question. That Minette is wondering more about professional development opportunities that can be shared between ECE staff and home visiting staff.
This is Janet, and I'd be happy to take a stab at the question.
Great.
Okay, we have a competitive innovation grant that we received from HRSA that we're partnering with the state of Virginia, and we've created the Institute for the Advancement of Family Support Professionals. So I will type in the chat the web address for that. It is free. Anyone can use it. In several states, they have wrote it into their their preschool development grant application. In Iowa, I know we're looking at how to make this work for childcare, and it's available and it's free. So it's not that it's not accessible, but we want to make sure that the CEUs can be awarded to childcare providers. There is CEUs are attached to all of the different modules that are available, and there's over 50 modules already available, and more will be added all the time. It's all online. It is free. There is a cost for CEUs. There's a cost for college credit. There is an exam. If you wanted to take the exam, there may be a cost for that. But otherwise, access is free. Anyone can use it, and there's so many different creative ways that you could use that in your community and build that, that commonality across the early childhood system with some things that you may would want to add specifically for childcare. Like I said, this is designed for home visitors, but when you go in and you look at it, and we've had many people do that, they've said, wow, this is certainly appropriate. When we talk about family engagement, we talk about lots of different things, safe sleep. Those are things that childcare needs to know. Those are things that you know, anybody working with a child needs to know about. So I'll type that in, but that is one resource that's available to you right now, and it is at no cost.
And this is Lauren. I just have to piggyback on that for a moment and say that in one of my other roles, one of the other hats that I wear is with the HB Impact Technical Assistance Center, and I send folks to the website that that Janet's going to put in the chat. I send folks to that daily. It is phenomenal.
Okay, I'll just add, I mean, I think when thinking about training across the disciplines, I think I always think about it in two different ways. I think one is like some of the competencies around parent and infant and early childhood mental health and the sort of hows and whens and whys. And then the other one is you know, the just sort of like a holding space for this idea of reflective practice, which sounded so central in the way that our colleagues from Iowa were talking about their use of mental health consultation, which is just so brilliant, right? So I mean, I think some of the models around, like the Fussy Baby or FAN model from the Erickson Institute in Chicago, or other models like that can cut across disciplines but really support reflective practice and therefore application of all the competencies is important to think about as well.
Thank you, Kate. That is really, really useful. And there's another link I'm just going to put in the chat that I think might be useful to some of you as well. So this is the link for the Center of Excellence for Infant and Early Childhood Mental Health Consultation. There's a toolbox that's available on the SAMHSA website. And in here, there's a lot of information that there's information for home visiting, for ECE. There's a lot about different kind of training opportunities, so that might be another resource to explore in terms of this cross-discipline training. It is not easy work. So another question has come in, and this is directed to you, Kate. So Tara is wondering, so she's saying that they use a braided funding model in their home visiting program, but have issues retaining family support workers due to the low salary of that position. And she's wondering if you've identified ways to supplement salaries with your model.
I think that's a great question, and I think something that, at least in the state of Maryland, which has a fairly high cost of living across the board, is something that I think in all early childhood spaces we're struggling with right now. So all I can do is empathize with that question.
Yeah, the overall staff retention due to low salaries is unfortunately, Tara, not something that your group alone is struggling with. It is definitely a universal struggle.
Lauren, this is Janet. Can I share really quickly something that we're doing in Iowa? And okay, this is just for McV home visitors at this point in time. We're getting ready to expand it to supervisors and then to another a state-funded home visiting program. But we started small scale again. But we call it the PAYS program. It is similar to the wages program for child care, but this is for home visitors. And PAYS stands for Performance and Education Yield Success. And what we're looking at are specific performance targets. If they are met during the quarter, the home visitor gets a stipend sent directly to them. We first started to do this with working with the organizations, and too many organizations could not do that, of turn around, or were refusing to do it, to give money to a financial incentive to their staff. And since they're not our employees, it made it difficult. But what we did was we do a contract directly with the employee. It's not ours, and they get a financial incentive. And it's only like $250 a quarter. That's $1,000 a year. Last year we spent $45,000 is how much the program cost us, but we lowered. We had less than 5% turnover in McV last year, and I really credit it with this PAYS program. It's a little bit of money, but it helps people know that we care about them, that we're thinking about them, and we're trying our best to get more money in their pocket.
Wow, that's fantastic. Is there a place, any links that, or if someone wanted some more information on that, Janet, would it just be best for them to get in touch with you?
Yes, I know we're putting together kind of like a little kit so other states can take this and replicate it, because again, it's not that costly. And I know we've got I think it's either at the Home Visiting Summit or it's at the McV All Grantee meeting. So in a few months, I should have like a kit that I could just give you that has everything that you need to know. In the meantime, I'll do my best to answer questions and get people information.
Very cool. Thank you for sharing that. Okay, we have another question that's come in from Jill. So she is wondering, I think this is open to anyone, do any of your programs work specifically with fathers or same-sex parents, and what are your outcomes in regards to engagement efforts or any other types of outcomes?
Well, this is Janet again. I'm sorry. I feel like I'm talking too much. But we don't have any programs that target specifically fathers or same-sex parents. However, we do have a lot of single fathers and a lot of same-sex parents that are enrolled in our programs. And I shouldn't say that we don't have any, because we do have some state-funded programs that are dads programs that are specific for dads. If they're more group-based parent education than they are home visiting, I think that we could be doing a much better job, and it's something that we have been working on for 20 years, and yet it doesn't seem like we ever quite get it. I think part of the issue is that our home visitors are mainly all female, and that is because of the low wages. And I think we would do a better job of engaging if we hired more people that reflected the families that we're trying to engage in our services. We're trying that with a diversity program, but it is looking at ethnicity, not necessarily gender. But it's a good question.
It is a good question, and I do want to just put out there, I think for you, Jill, and for Taryn, just some other questions that have come in or that might be on folks' mind with some more specific home visiting types of implementation questions. If you want to send me an email, there are some different resources that HV Impact, the TA Center that I had mentioned before that I'm also a part of, that does the implementation support with McV. We have a lot of resources, certainly on staff retention and some other related issues that I would be happy to send your way. All right, other questions, thoughts? Again, feel free to either use the chat or to speak up. Just give folks a moment to see if there's anything else in the chat. Jill, I'll put my email in here right now so everyone will have that. Sorry for my... Okay. Yeah, so please do feel free to email me. There are just lots and lots of resources out there. I'd be happy to send some your way, and also can get you in touch with your, happy that everyone's on here from different places, so we can do lots of different connecting. Other questions, thoughts? And if not, I'm so grateful to Kate and Janet and PJ for participating with us today. This has been really fun for me because this is just bringing so many of my my interests together. You know, you put home visiting and systems of care and mental health consultation all together, and it's just a beautiful thing. So really appreciative of your time. Very appreciative of everyone's time that was been on the call today. You have been a terrific group and asked lots of questions. We are going to be taking the survey, but before we close, I did just want to talk really briefly about this learning community. So it's had several different iterations over the past few years, and we traditionally have done it about every other month, but starting in 2019, we are going to be doing it more frequently, and we are going to be, we've always tried to be very intentional about the inclusion of the family voice, but we are really going to be increasing that. Really interested for anyone's thoughts on different topics and ideas. We're going to be doing a quick poll for the learning community as well, and so within the evaluation. So please do click on that link. Let us know of anything that would be of interest to you. Keep an eye out in the TA Telegram for more information, and we will be looking to disseminate in some other avenues as well. So we're really looking forward to being able to offer this even more frequently. But we do need you to take that evaluation so we can know what we are doing well and what we can do even better. Jill, the slides should be available. If you look just down below the public chat, there's a little file pod. And so there's the family support document that PJ and Janet had mentioned, and then the second, if I'm right here, the second download should be the slides. All right, I'm going to just leave it open for one more minute and see if there are any other questions or thoughts or anything that comes up for anyone. And if not, I'm happy to give everyone a few minutes back in their day. All right, well, please do click on the survey and join us next time. And thank you all very much. Have a great rest of your